Assalamu alaikum. Our lecture today is the occlusal device or splint. Well, there are many definitions of occlusal device, but it could be defined as any removable artificial occlusal surface used for diagnosis or therapy affecting the relationship of the mandible to the maxilla. Or a newer definition, according to the Glossary of Prosthodontic Term, 2017, it's any removable artificial occlusal surface affecting the relationship of the mandible to the maxilla, used for diagnosis or therapy. Uses of this device might include, but are not limited to, occlusal stabilization for treatment of TMJ disorder. Other name, it could be a bite guard, mouth guard, occlusal appliance, occlusal splint, orthotic device, stent, and surgical splint. Well, the types of occlusal splints according to Dawson, we have first the permissive occlusal splint, which has a smooth, flat surface on one side that allow the muscle to move the mandible without any interference from deflective tooth contact or incline, so that the condyle will seat back up to the eminentia to complete seating into the circulation. Well, these devices are generally used to treat muscle pain disorders, and also some studies have shown that wearing it can decrease the parafunctional activity that often accompanies period of stress. Well, the second type, it is called the directive occlusal splint. It has an indentation, so it will direct the lower arch into a specific occlusal relationship that in turn will direct the condyle to a predetermined position. Actually, it will encourage the mandible to assume a position more anterior than the intercuspal position, so that it may be useful for the management of certain derangement disorders. But generally, the directive splint have very limited use, and they should be reserved for a specific condition involving the intracapsular TMJ disorders. Well, the uses of splint, uh, actually, the splint may be indicated in the following circumstances. First, prevention of tooth surface loss, especially in those patients who have night bruxism. So, by routinely wearing an occlusal splint, it might minimize the damage to the tooth surface. And second is in the management of mandibular dysfunction, because many studies have shown that an occlusal splint may be beneficial in reducing the pain experienced in mandibular dysfunction. And third, in case of pre-restorative stabilization, and especially in this case, you are going to create a new stable intercuspal position at the retruded position when the stability is absent. So by using an occlusal device, the patient will go back into a more stable retruded contact position. And fourth, protection of a new restoration from parafunction. Even if you do restoration for the worn teeth, It is advisable for those patients to wear a post-restorative splint to protect the new restoration from damage. And the last is the creating space for the worn anterior teeth. As you can see in this slide, the intercuspal position showing contact between the mandibular incisal edge and the opposing teeth. And after 1 month of occlusal splint therapy, the mandible is retruded into more stable retruded contact position, creating space anteriorly to restore the worn anterior teeth. Actually, the existing discrepancy was hidden because the patient neuromuscular system has hidden the discrepancy between the RCP, the retruded contact position, and the intercuspal contact position. But after 1 month of occlusal splint therapy, the mandible is retruded back into the more stable retruded contact position. Well, the principle of using an occlusal device, according to Dawson, most occlusal splints have one primary function, is to alter an occlusion so it does not interfere with complete seating of the condyles in centric relation. Well, we have many types of splints. The partial cover splint, an example, are the anterior deprogramming splint. Actually, these are used in case of muscle spasm. It will relieve the pain quickly, but it should be worn continuously. And if we misuse these devices, it will cause intrusion of the covered segment and over eruption of the uncovered segment. So it is advisable, if you want to treat the patient for a long period of time, to cover all the teeth to prevent the previously mentioned problem. Well, another type of partial coverage splint, it is what's called the midpoint stop device, or the trigeminal tension suppression system. It's the same idea as for the anterior deprogramming. It will only cover the central incisors, so the mandible will rotate only anteriorly, and it will be seated properly at the retruded contact position. And they believe that this device will suppress the headache or the trigeminal neuralgia, but actually it is not supported by longitudinal clinical trials. And the same the drawbacks of the anterior deprogrammer, as the intrusion of the covered area and the super eruption of the uncovered segment is going to be occurred if it is used for a long period of time. Well, another type of partial coverage splint is the posterior bite plane, and the treatment goal of this bite is to achieve major alteration in vertical dimension and mandibular positioning, and actually it is advocated to be used in cases of severe loss of vertical dimension, or when there's a need to make a major changes in anterior position of the mandible. But actually there are a few data or studies to support the use of this type of appliance, and the main drawbacks, as you see, as shown in these pictures, are the intrusion of the covered segment. Other type of appliances, this is called the pivoting appliance. It has a framework of cobalt chromium and a flat occlusal surfaces bilaterally to be contact with the first molar only. And the idea of this appliance is to reduce the interarticular pressure, and thus by unloading the articular surfaces of the joint. And also some claim it will be beneficial in case of joint sound, but actually data do not support that this appliance will reduce the joint loading. Where another appliance, it is called the hydrostatic appliance. It is actually a bilateral water-filled plastic chambers attached to an acrylic palatal appliance, so that the posterior teeth of the patient will occlude against a soft water-filled chamber. And the idea behind this appliance is that when the mandible will find its way automatically by occluding against this water-filled chamber, and then relaxation to be encountered. But actually, there is no evidence to support this claim till now. Well, the choice of materials for the splint, it is a matter of controversy, but actually the material of choice is the heat cure or the laboratory processed acrylic resin. It is a reasonably hard material which may be easily adjusted, and also it is durable enough to serve as a protective night guard. Well, those who believe with the resilient devices, actually it is of limited use, although it is quick and economic to make, but they are soon will be destroyed by the bruxers, and their resilient surface is not amenable to the production and maintenance of the stable occlusion necessary to achieve muscle relaxation. Well, the choice of whether the using of maxillary or mandibular splint depend on classification. In case of a class 1 and a class 2 incisor relationship, so it is easier to produce an ideal occlusion with a maxillary appliance, while the converse is true in case of a class 3 situation. But anyhow, the maxillary appliance provide more stability, since all mandibular contact are on flat surfaces, and this may not be possible with a mandibular device, especially in the anterior region. Well, Splint design, the design preferences is very widely between clinicians. Those who may choose the upper, other choose the lower appliances, and those who use a flat surface with interlocking devices, and those who prefer with anterior guidance and other without, and different thickness has been proposed, but all these preferences are not supported by outcome studies involving randomized clinical trials. But there is a general agreement that the full arch stabilization splint remained the gold standard for therapy for patients with temporomandibular disorders, and the most common appliance used around the world is the stabilization, the Michigan Splint. This is made of rigid materials with a flat occlusal plane and a ramp providing anterior guidance. Well, this is an extra photograph of the Michigan stabilizing splint. Is to be seated on the maxillary teeth when the jaw are slightly opened, and rotation to be achieved by frictional, and the coverage of the teeth will be increased as we go backward, so that the coverage anteriorly upon the labial surface of the incisor and canine will be 25%, and there will be 33% coverage of the buccal surface of the premolars, and the buccal surface of the molars will be covered by 50%. Well, for the fabrication of the appliance, first of all, how to prepare the cast. You have to make an upper and lower alginate impression in stock trays, and then you pour it with a stone materials. And an important thing is to block out any undercut on the maxillary cast, so that to reduce the chair time when fitting the appliance in the future. And the appliance should extend 5 to 10 millimeters into the palate beyond the palatal gingival margin. Well, how to make the Michigan stabilizing splint? First of all, a thermosetting clear blanked material is to be pressed upon the stone cast by means of a Biostar vacuum machine, and the thickness of this material will be 2 millimeters to be adapted over the molar surface and the palate, as you can see in this frontal section. And also an acrylic addition will be built up upon this clear template, another 2 or 3 millimeters, to form a flat surface to be contact by the buccal cusp of the mandibular molars and premolars. And also you can see a sagittal section through the maxillary central incisor. The same, you can see a thermosetting clear plank of 2 millimeter thickness, and we build an acrylic over the clear thermoset template, and we form an anterior ledge anteriorly to act as stoppers for the incisors for centric relation, and also a 45-degree anterior ramp is to be created to help you or to guide the patient in the eccentric jaw relations. Well, after fabrication of the Michigan occlusal splint is to be adjusted on the articulators. As you can see, at centric retruded contact position, the contact will be on the flat occlusal surfaces and posteriorly, and on the ledge anteriorly to form as you can see. And in case of a protrusion, the contact will be on the ramp anteriorly, and if there is any contact in in the posterior segment should be eliminated, and also in case of eccentric movement, the guidance will be on the ramp, on the canine, and if there is any contact on the non-working side should be eliminated. So briefly, in centric relation, all the contact will be on the flat surface posteriorly and on the anterior ledge anteriorly, and in case of a protrusion, the contact will be only on the ramp anteriorly, and posteriorly there will be disocclusion. And also in case of working contact, the canine will guide on the ramp, and any non-working side contact should be eliminated. Well, how to make the Michigan Splint? As you can see, this is the vacuum pressure machine or the BioStar machine, and a clear thermal setting template to be pressed against the maxillary stone cast, and after that the excess material to be cut by a disc, and lastly finishing by means of a lathe machine, or you could use an acrylic burr on a prosthetic handpiece. Well, after completion of the thermosetting BioStar, a buildup of the occlusal surfaces. There is different technique, and this technique is using the autopolymerized cold cure acrylic to fabricate the flat occlusal surfaces anteriorly, and flat occlusal surfaces posteriorly, and the ledge and the ramp anteriorly. Well, after complete adjustment of the appliance on the articulators, the device will be refined again inside the patient mouth. So the patient is seated on the dental chair, and the operator uses articulating tape and a handle to guide the mandible into the rooted contact position, protrusion, and to the working side from the right and left. And you check the occlusal contact at centric. It will be on all the flat surfaces, and also you check the guidance by the anterior teeth during protrusion, and the guidance by the canine during working, and also you may eliminate any interferences during protrusion and movement to the working side from the right and left. Well, another technique to fabricate the occlusal device is to use a wax, and if you want to stabilize the device more, you can add a clasp to the appliance. 4mm thickness of wax is to be adapted on the maxillary cast and to be adjusted on the articulators. And then after waxing, you're going to form a putty, a silicone putty to form a mold, so that after putting the wax in a hot chamber for wax elimination, then an cold cure acrylic to be poured through the holes, and then curing to be accelerated by putting the mold in the pressure cook, and after complete polymerization, reseat again the appliance on the maxillary cast and do the necessary adjustment. Well, the review appointment of the splint. Usually the occlusal splint for therapy must be worn for 24 hours a day except to eat and brush until the occlusion and TMJ become stable. And stability is determined by 3 verification. First, elimination of painful symptoms, and second, verification of centriculation by load testing. That means you guide the mandible into a centrical relation, and gentle pressure. The patient should be feel no pain and comfort. And third, stability of the bite on the splint over the course of a few days or weeks if joint damage has occurred. Well, generally for occlusal muscle disorder, these results are usually achieved within a matter of days and not a month or years, and the average length of splint therapy for occlusal muscle disorder or spasm is 2 to 4 weeks to achieve a stable occlusion. Well, in case for bruxism, the treatment is longer. Review appointments should be every 2 months over the first 6 months are desirable to determine when symptoms improve, indicating that patient may start to reduce the frequency of splint wear. And also there may be a need to return to using the splint if the symptom worsen again or if the patient realizes from their self-monitoring that there has been an increase in clenching, particularly at time of stress. Well, an important thing that I bring you this study from the Cochrane Library, which is specialized in evidence-based dentistry and are well-published systematic review studies. In one study entitled Occlusal Splint for Treating Sleep Bruxism, the author conclusion was that there is not sufficient evidence to state that the occlusal splint is effective for treating sleep bruxism. Indication of HCUs is questionable with regard to sleep outcome, but it may be that there is some benefit with regard to tooth wear. And again, this systematic review suggests the need for further investigation in more controlled randomized clinical trials. And finally, thank you for your kind listening.